you for joining us for the CME, for the webinar on the theme Advancing Care in Precision Medicine, Evolving Treatment Strategies in HR-Positive Metastatic Breast Cancer. It gives me great pleasure to introduce our chairperson, senior medical oncologist, senior consultant medical oncologist from Bombay Hospital, Mumbai, Dr. B.K. Smruti, ma'am. So now I request ma'am to please give the opening remarks. Over to ma'am.
Yeah, so at the outset, before I begin, we would like to convey our condolences for the sad demise of our very esteemed and loved senior pathologist, Dr. Anita Borges. And I think we really regret the way, she has passed away at an early age. So with this, I would like to start the proceedings. I have great pleasure in inviting and introducing our esteemed guest, speaker, Professor Giampaolo Bianchini. He is the Associate Professor at Vita Salute San Raffaele University and Head of Breast Oncology at the Department of Medical Oncology of the IRCCS Raffaele Hospital, Italy. He is also head of the Clinical Translational and Immunotherapy Research Group at the Department of Medical Oncology. He graduated in 2000 in medicine surgery from the University of Milan and specialized in medical oncology from the University of Milan. He has been a visiting scientist at the prestigious American institutions such as the NCI and the MD Anderson Cancer Center. He has several research projects dealing with breast cancer and such as understanding the mechanisms of response and resistance and new therapeutic strategies and biomarkers. He has the distinction of authoring numerous publications in very reputed journals like Nature, Lancet Oncology, Annals of Oncology, Journal of Clinical Oncology, and so on. So with this, I would like to invite first our first speaker, that is Dr. Moushumi Suryavanshi. She is the head of senior consultant and head molecular biology and cytogenetics at the Amrita Hospital, Faridabad. So I invite Dr. Moushumi Suryavanshi to give her presentation.
Good evening, everybody. Can you see my presentation?
Yes, ma'am, we can see.
So, and first of all, thank you organizers for giving me this opportunity. And again, I would also like to pay my heartfelt condolences for Dr. Anita Borges. She was actually the icon of pathology, and she's the one who's actually led the torch, and we are just following behind her. So our topic today is the molecular monitoring of ctDNA and ESR1 mutations. So in breast cancer, over 2/3 of the breast cancer patients are hormone positive and HER2 negative. So that is the bulk of disease we are going to talk about today. And in hormone positive, HER2 negative advanced breast cancer, first line of therapy is the key to response. If you just look at this graph, most of the response comes in the first line, around 24 to 28 months. And in the subsequent lines, the response decreases up to 60%. So we use CDK4/6 inhibitors, which is a big clinical success, but we do not use any relevant biomarkers to predict the outcomes. So this response in the first line decreases because of the pressure of the therapy and because of endocrine resistance, which plays a big role. And the endocrine resistance is mainly brought about by the ESR1 mutations. So presently what we are doing is that when there is in the first line, after there is resistance, clinical progression after the aromatase inhibitors, we do test for ESR1 mutations, and if they are present, then the SERD are offered, SERD. But now this is a different game changer where we are trying to test ESR1 mutations before the clinical progression. And that is why there is so much importance to ESR1 mutations, and we need to understand the nitty-gritties of these mutations. So what is happening? Here our estrogen, which brings about its action through the ESR1 receptors, and these receptors, when they have mutation, the estrogen pathway which was feeding the tumor was inhibited by the aromatase inhibitors is no longer inhibited, because there are mutations in the receptor, that is the ESR1 R1 mutations, and this causes constitutively activation of the pathway and multiplication of the tumor cells. That is, the aromatase inhibitors do not function, they stopped working. So if you just look at the prevalence of ESR1 mutation in tissue as well as the liquid biopsy specimens collected in the first 3 metastatic lines of therapy, in the early breast cancer, there are hardly any ESR1 mutations in tissue or liquid biopsy. But in the metastatic setting, after the first line, there are ESR1 mutations are seen in around 5% of the patients, and in the subsequent line, the ESR1 mutations keep on increasing from 33 to 40% in the third line. Vis-a-vis the other mutation like the PIK3, AKT, and PTEN, which we are also looking at progression. These mutations are actually, if we do sequencing of the initial tissue, these are initially present in the tumor. But ESR1 mutation, unlike these PIK3, CKT pathway, AKT pathway, are obtained later on post-therapy. So where are these mutations located? So this is the line diagram of the structure of ESR1. And you can see that most of the mutations are located in the ligand binding domain. Though occasionally literature has reported some of the mutations in the AF1 domain also, but predominantly most of the mutations are hotspot and are located in this domain, which is from 400 to 595 amino acid position. So ctDNA mediated serial ESR1 testing to detect acquired endocrine therapy resistance. So this becomes important because previously we have been doing ESR1 mutation when we found a clinical progression. Now we are moving to an area where we are going to test for ESR1 mutations before the actual clinical progression. So there is this unmet need to detect resistance of endocrine therapy earlier in patients with metastatic breast cancers who are on AI. So, and to document this, the clinical evidence has started from PADA-1 trial, and now SERENA-6 has also shown very promising results. And in this particular trial, there were around 3,325 patients who were already on first-line AI with CDK4/6 inhibitors, and more than 6 months, these patients were tested. And why more than 6 months? Because it was seen in the PADA-1 trial that most of the patients who developed these ESR1 mutations developed after 6 months and not more than 30 months. So the range of testing is from 6 months to 30 months where these mutations have to be tested, and this evidence comes from that trial. And in that PADA-1 trial also, it was seen that the patients who had ESR1 mutations were who were younger, who had a more of estrogen positivity, and who also had more of bone mets. So building on that, this SERENA-6 trial, so these patients were screened, and they were screened every 2 to 3 months for ESR1 mutation testing, and they were found positive on the first test, second to fifth test, or more than 5 tests. Actually, 42% of the patients of these patients turned out to be positive. And in this particular trial, out of these patients, only 548 patients were positive for ESR1, and among these 315 were randomized for the trial. So I'm not going into the details of the trial, but what I will be talking here is about the ESR1 testing. So this, of course, is done by liquid biopsy, and by liquid biopsy, I think most of you are aware that it tells us about the heterogeneity. And in breast cancer, and more so for the mechanism of resistance. So these mutations are heterogeneous and may not be picked up always by the tissue biopsy, and there can be multiple ESR1 mutations in one metastatic site or other metastatic site. So based on that, the ideal sample for testing ESR1 mutation is the liquid biopsy. And in liquid biopsy, these are the fragments of DNA, of the tumor DNA, which are found in the blood. And if you can see here, uh, okay. So what is seen here, this is the DNA and it is coiled around these nucleosomes, and this particular length of this one coil is 170 base pair. So that is the length of the DNA of the cell-free DNA, which is unlike your normal DNA. And this is how we in the lab can pick up the cell-free DNA. Most of our cell-free DNA fragments are 170 base pairs. So that is how we know that that sample has cell-free DNA. So why tissue and why not tissue and why liquid? You can see here clearly that the positivity of ESR1 in tissue in the first line, second line, and third line. This is tissue, this is liquid, and in the tissue it is 8%, in liquid 10.4, and again 27%, around 38%, and then 33% and 38.7%. Clearly, the positivity is much more in the liquid biopsy. It is not like what we do in lung cancer. It's not like a reflex testing. The liquid biopsy is good enough. So when is the right time to test for ESR mutations, and how long ESR mutations are to be monitored? As mentioned previously, this has come from the part of one trial, which clearly showed that the patients were positive only after 6 months and not more than 30 months. So that is the range when this testing has to be done. So then integrating this into the precision medicine approach, how do we go about it? So we need to know about the test and what are the qualities of the test. And I think the clinicians should know about it so that they can order test, and they should know what is expected of the test and what cannot be expected of the test. Actually, there is no perfect test, but there are certain qualifications which you do need to know. This mutation, as we know, is not being present de novo, and it has come after the pressure from the treatment or the therapy that has been given to the tumor. And the test should be sensitive. It has to be performed on liquid biopsy. It should be covering most of the hotspot, as most of the mutations were in the ligand binding domains. It has to be low cost because it has to be repeated again and again. And additional tests, since there are also PIK3 CA or AKT mutation, so additional tests might also be required, which can also look at those mutations if you need to add those drugs to the therapy. So there are various approaches. So in the approaches, there are these PCR-based approaches and the next generation sequencing-based approaches. PCR is the routine PCR, which has been used for your like EGFR testing and all PIK3CA testing. And then there is a more sensitive PCR, which is the droplet digital PCR. The sensitivity of this PCR is more. And but the limitation of these PCRs is these cannot go beyond what is put in the test. So you cannot know if anything more is present in the test, only what has been added in the test. Like for what the primers are there, you can only pick up those, and there is a limit to the number of the hotspots you can add in a PCR. So that is one limitation. But the sensitivity wise, droplet digital wise is in fact as good as, or even at times better in sensitivity than your next generation sequencing. Then of course there is next generation sequencing, which is costlier, and you can look at many mutations in one go. And not only the hotspot, you can also find novel mutations there. So that's a big limitation for the PCR-based technologies, which are not present. So these are the list of some already available ddPCR and PCR based tests. And what you can see here is the sensitivity of these tests is very good. Most of them are able to report up to from 0.03 to 0.1. So this is a very good sensitivity for this. But what you should know is that they will not be covering all the mutations. all of them have different mutations, and that then the clinician should be aware of them, that at least the common mutations are covered in these tests. And these are the list of mutations which are covered in these commonly available tests in the market. And these are the commonly available NGS tests. These NGS tests can also be like these are already well known NGS tests, but these can also be made by the lab, so which can be lab developed test. And again, the sensitivity is good, and they have their own advantages, but cost, of course, is a concern here. So then in liquid biopsy, the most important thing is the pre-analytical variables. So there is, I just put this figure because this is the story of Rumpelstiltskin, in which there was this little monster who could make gold from straw. But in real life, there are no fairy tales. No technology can spin straw into gold. You must begin with gold. So your sample is very, very important. So there are many parameters, pre-analytical testing variables which need to be looked at. Time of first processing, the initial draw, the samples have to be, if it is within 4 to 6 hours, they can be in EDTA, but then there are specialized Trek tubes or some Paxgene tubes, and there are so many other cell stabilizer tubes which are available, which can keep the cell-free DNA stable up to 48 hours and at room temperature. So the temperature is very important. The tube is important. The tube has to be shaken properly. The tube inversion is very important. And these all things, the clinician should make sure that it is done. It is not that you do such a test and ultimately it comes out that the report cannot be given out. And processing, of course, is important. That is, of course, you need to go to a good lab, and there are certain parameters which need to be processed. And then storage also for the lab is important. We need to allocate it, and we cannot just keep on freezing and thawing it again and again, so that the viability of the cell-free DNA decreases. And of course, there is documentation, there are guidelines how to do it. So this is just to show you. So these are hemolyzed samples, and when these samples come in the lab, we need to double centrifuge them. And you can see here, this is a normal cell-free DNA, and this is a sample from hemolyzed cell-free DNA, and this will be contaminated by the genomic DNA, and your yield will not be that good. So this part the clinicians have to keep it, and this is how we see in the tape station. This, as I earlier showed, is a 170 base pair normal good sample with normal cell-free DNA. And if there is hemolysis, if the sample has not been taken properly, or it is an old sample, you can see lot of contamination by the genomic DNA. The WBC DNA contaminates it, and it can really affect your results. And the CAP and AMP has given lot of recommendation to the sensitivity of the test is very important. You should know how your test is performed and how sensitive it can be. And there are other parameters like interference. This is usually based on the chip, which is more for other tests. I think ESR1 doesn't appear in chips, so there are nothing you really need to worry about, especially for ESR1. But for other mutation, yes, there could be clonal mutation coming from WBC. And then the validation of the lab, the orthogonal method used is very important. So the clinician should look into what the test is doing and discuss with the lab, so what they have done for the validation, and they usually have a validation summary which you can look at. So again, not only the pre-analytical variables, but there is reporting guidelines also provided by the AMP and CAP recommendations are there. So these again have to put in all the things, the test for which the indication of the test, and the monitoring, what level monitoring, all those details have to be given by the lab itself. So I was just looking at what is there any data on ESR1 mutations available from India. So this is what I could find. So this is an abstract published in 2024 of 80 cases on tissue, and they found some 27.5% patients who were positive, and the commonest mutation was L536, and which is usually it is 536, 7 and 8, either of them is the commonest. And in the post aromatase inhibitor patient, there were 30% patients who had it. Post tamoxifen, 27.3% patients had it, and about 50% of the patients also had PIK3CA mutation along with that. So not only your ESR1 mutation, but you also need to know there may be other mechanism of resistance. And this particular study was done based on NGS testing. So I just looked at our data. So we are a very recent lab. We just started last year in February, and we have done some 150 comprehensive genomic profiling, and there were 7 hormone positive breast cancer patients. So I found one case in tissue with ESR1 mutation as well as one with ESR1 fusion. So you should also be vigilant. If you're doing NGS, you might be finding some other things. So there may be fusion, which could also be, and even amplification, which could be resistant mechanisms. And this is our liquid biopsy data. Again, we had 4 cases of in our comprehensive liquid biopsy, and 2 of them also had PIK3 mutations along with that. So it is ESR1 is, yes, of course, one part of the story, but there may be other parts of the story. And with that, the key takeaways are ESR1 mutation may predict aromatase inhibitor resistance in patients with hormone positive HER2 negative metastatic breast cancer. ctDNA mediated serial ESR1 testing has potential to predict relapse before clinical progression. The ideal interval of testing is 6 to 30 months. ctDNA mediated serial ESR1 testing can be integrated into a lab's workflow using the available approaches and resources. With that, thank you. And I will stop sharing.
Thank you,
Smruti, ma'am.
Dr. Yeah, thank you, Dr. Moushumi, for that excellent overview of the development of mutations induced by treatment of metastatic breast cancer. And at the moment, we don't have questions, but I think you could stay on. We could ask questions during discussion of the various patients. So now we move on to our guest speaker, Professor Giampaolo Bianchini, and he is going to tell us, how to overcome the ET resistance in the era of precision medicine. So over to you, Dr. Bianchini.
Yes. Thank you very much for
So we lost you in between. Sir, you're on mute, sir. Can you unmute your mic, sir?
I hope that I have some signal that the connection is unstable. I don't know why. Usually is working very well, but anyway, this is sometimes what happens. Okay, just let me know if you don't hear me well.
Sir, we're hearing you perfectly well right now, sir. And we can see your slides as well.
Oh, that's perfect. So first of all, thank you very much. I've been recently in India for the first time a few times ago, so I really enjoyed the country. So it's a pity that I could not be there in person. Hope that we have a nice discussion. I would like to put a little bit in context. These are my declaration of interest. Probably the most important thing that I am a steering committee member of Serena-6. So, of course, I have a personal opinion that can be influenced by these, to be totally open. I don't feel so. I think that my opinion is usually very independent. But what I would like to start is the old ESMO guideline about the treatment landscape in ER-positive, HER2-negative, essentially say endocrine therapy, CDK4/6 inhibitor for all comers. The question is, but does really one size fits all? And we don't care about biological heterogeneity. Indeed, what we know in ER-positive to negative breast cancer, as the previous speaker has very well described, that there are several molecular alterations that are valid target for therapy, starting with the target of ADC, estrogen receptor, CDK4/6, mTOR, AKT, PTEN, PI3K, and BRCA mutation, PARP2 mutation, and somatic BRCA mutation. But come to the first line, the new ESMO guideline really changed you see the presentation, and recognize that in tumors that are classified as endocrine therapy resistant, primary or secondary, now we have two options, not one option anymore. And one of the options is available only if you have a PI3K mutation. In this case, if you have a PI3K mutation, you have the option, the standard option to give fulvestrant plus CDK4/6 inhibitor, or fulvestrant plus palbociclib plus inavolisib. Why this treatment? Because of the NAVO 120 trial. NAVO 120 enrolled endocrine-resistant patient, randomized, palbociclib plus fulvestrant compared to the same combination, but plus inavolisib, that is a new PI3K inhibitor. These are the overall response results. It is really remarkable in this population at 62.7%. Yes, 62.7% response rate. And you know, the duration of response is very long. They are much longer. It's just that more response, but the quality is also higher. This is the updated results for the PFS analysis. You know, a reduction of risk of progression of more than 50%, and a median PFS that go from 7.3 months to 17.2 months, almost 10 months improvement. So really, really a huge benefit. And probably the most important, this treatment drive a statistically significant overall survival benefit with a reduction of risk of death, proportional reduction risk of death of 33%. So that is for sure an option that we should consider. What about post-CDK4/6 inhibitor landscape? One size fits all? No, but that is already implemented the previous guideline. And you see that there is a target-driven selection. We will come back at the end of the presentation. But it's important to identify PI3K mutation, AKT1 and 10 mutation, ESR1 mutation, or the mutation of homologous recombination deficiency like BRCA and PARP-B2. And indeed, the updated NGS recommendation for ESMO say in estrogen receptor positive HER2 negative breast cancer, so not all the subtype, not triple negative, not HER2 positive, at progression, read in red, at progression of resistance to the first-line endocrine therapy, a test should be carried out to really identify the patient that should candidate for a following therapy. So this assessment can be done by ctDNA. In the previous presentation, everything was important of the technical part of ctDNA was explained. So very good, easier for me. But the first potential application of ctDNA is to match a molecular landscape with a treatment. Yes, it's useful. We can later discuss if sometimes we need to use the solid tissue. Now I want to mention another potential application of ctDNA in metastatic breast cancer, that is to monitor the treatment response. What does it mean? You can potentially have an early assessment of treatment benefit and resistance that can be useful to optimize treatment by switching to alternative therapy. So what does it mean? The dogma in metastatic breast cancer is like a dogma, is that we change the treatment when there is a progression, a clinical progression. The clinical progression can, for instance, follow the RECIST criteria, the one that you use in clinical trial. But can we challenge this dogma? It's really true that we have to change the treatment only when we have a clinical progression. And the RECIST actually do something like this. So you have a patient with a disease. We follow the patient with the same imaging techniques. In this case, you have a partial response. and then again, you have a progression disease. So this is called a longitudinal monitoring. So the idea of having liquid biopsy reaches is to apply the same dynamic assessment looking at the ctDNA instead of solid tumor to get what is a molecular progression. If you read this very nice publication, in Annals of Oncology, you really go in deep of this new concept. So now come and focus on endocrine sensitive NA patient. Can we combine these two potential applications of ctDNA, detecting molecular alteration for which we have a targeted therapy and detecting molecular progression in one trial? Yes, has been done. SERENA-6. SERENA-6 trial evaluate the clinical utility of both. We come back on this, of both targeting an emergent druggable acquired resistant mechanism, ESR1, and switching treatment at molecular progression. Just to remind, when you have an endocrine sensitive tumor, you give an aromatase inhibitor plus a CDK. Aromatase inhibitor because you decrease the ligand estrogen. So what happens that the tumor sometimes find a way to escape, developing a ESR1 mutation. ESR1 mutation means that the mutation allows the receptor to bind to the DNA without the ligand. That's why there is an overcount. So you need an estrogen deprivation environment to develop a ESR1 mutation. So the appearance of ESR1 mutation is actually driven by an acquired resistance. And again, because you are in an environment in which you generate an evolutionary pressure. But what I want to highlight you is that when you acquire a ESR1 mutation, and part of this information was already touched in the previous presentation, you reshape the cell biology toward a more aggressive behavior. What does it mean clinically? That when you have a ESR1 mutation, you don't just generate endocrine resistance. You also change the biology of the tumor. It becomes more oriented to a mesenchymal phenotype and many other characteristics that make the tumor grow faster and potentially metastasize more. Indeed, if you take a patient with a metastatic breast cancer at the same time, and you compare ESR1 wild type and ESR1 mutation, patients with ESR1 mutation have a higher risk of death. And you see on the right, has been demonstrated that ESR1 mutation increased the homing of the metastasis in the liver, in the bone, but especially in the liver. How we can target the ESR1 mutation? Of course, we've served product of other drugs that are degrader, because it's not enough to remove the ligand. So in this cartoon, you see the common situation. We start a treatment in endocrine sensitive, and we should not expect that the tumor at baseline, in general, have any ESR1 mutation. But under the pressure of the treatment, the tumor have the advantage if by chance generate ESR1 mutation. This clone has an advantage. So they start to dominate the situation. So you have a situation in which maybe you have still a partial response, so a clinical response, but if you look at the ctDNA, you have an appearance of ESR1 mutation when it's enough. This is called molecular progression. But the dogma is we change treatment when we have a clinical progression, so a progression disease. Of course, we still have a potential ESR1 mutation. So like the application of a lacestrant now is exactly in this situation. You wait for a clinical progression and you apply a lacestrant. So the SERENA-6 actually tests another idea, is why if I know that there is a molecular target and there is a molecular progression, not starting the effect in treatment at that time. And the PADA-1 trial with fulvestrant plus palbociclib really provide a proof of concept of this evidence. The PADA-1, to remind, was mentioned before in some of the slides as a similar, not the same design as SERENA-6, because all the patient was enrolled from the beginning of the treatment, but that is the results of PADA-1. So demonstrate that fulvestrant, that is a much less effective SERD compared to camizestrant, provide the benefit when you shift at molecular progression compared to continuing the same drug at no clinical progression. There are some caveats for PADA-1, just to remind, very important. This is an open label study with investigator-assessed PFS as the primary endpoint. So imagine the situation. You run a trial in which you tell the oncologist that the patient has a molecular progression, and they know that there is a group in which they are continuing the drug, and they know that there is a group in which they change the drug. Of course, the mind of the oncology is to keep the patient more if they receive a different drug, because they believe in the approach, and eventually give a progression very early on. If they know that there was a molecular progression, they see a TC, a little bit progression, they will give a progression. So it's very affecting the result. So that means the PADA-1 result overestimate the potential benefit of fulvestrant in this context. And also, most important, they use a suboptimal SERD. So we know that fulvestrant is not a very potent SERD. So now come to the SERENA-6. SERENA-6, very important trial, published on New England Journal of Medicine together with the presentation in the plenary session and ASCO. Plenary session means they recognize the value of the trial. The design was already being described, so I don't want to spend more time. There is a phase that is selection of the identification of the target ESR1, and another phase that is a randomization to the two strategy, shifting to camizestrant and continuing the same CDK, or continuing the same treatment till clinical progression. It's a double-blind trial. Blind means I'm blind, the patient are blind, everyone is blind. It's very important. This is the design again that summarize what I just said. The baseline characteristic was described in this structure. Just be careful here. Some patient entering the trial after many years of aromatase inhibitor plus CDK, like I put at the beginning some patient into the trial after 4 years of aromatase inhibitor and CDK4/6. So you cannot look at this proportion and say, okay, first test, subsequent test are really affected by this type of enrollment. But also tell us that potentially, if this strategy will be available, you can apply immediately to all your population, because exactly what happened with SERENA-6. You don't need to start from the beginning. You can test even a patient that is under treatment by 24 months, but at least 6 months of treatment without progression. This is the time. So 62% of the population have a duration of previous CDK or at least 18 months. And you see that despite the majority have received palbociclib, there is a 25% of the population that have received either ribo or abemaciclib. This is the benefit in terms of the investigator-assessed PFS. That was the primary endpoint. They came blinded trial, so not the bias that I mentioned before. They adjusted as a ratio of 0.44, so a reduction, proportional reduction of progression of 54%, so quite a huge benefit, and a median increase from 90.2 months to 16 months. I don't think median It's very important. Now, I want to comment with you about these results. So, first consideration. Let's consider the actual standard. So, Elacestrant is an option. I can tell you that in Italy, we have access to Elacestrant, but the real-world data say that the oncology at progression to CDK4/6 inhibitor or aromatase inhibitor, in 40–50% of the patients prefer to use chemotherapy because sometimes you have bad progression, a very high burden of disease, symptomatic disease, and they prefer to use chemo. Instead, the key point of the Serena is that all patients can be offered the targeted agent for ESR1 because it's a molecular progression. There is not the risk that you say, okay, I don't like this progression, I'm more sure to give chemotherapy. So that's the first hidden advantage of the strategy. The second one, if you look at the clinical data for Elacestrant, you see that overall, if you look at the patient with ESR1 mutation, there is 35–40% of patients that do not benefit at all. There are some patients that benefit quite a lot, but that means that almost 1 out of 3 patients is progressing at the first TC evaluation. If you look at the Amber 3 trial, we will mention later the design, but is with imlunestrant. Again, for ESR1 mutation population, it's the same. You see, 30% of the population is progressing at the first TC evaluation. And the PADA one has a small cohort that in the control group, the one that continued despite the ESR1 mutation to receive aromatase inhibitor and palbo, that at progression receive fulvestrant plus palbociclib. You see again a very limited activity, suggesting that it is really different the activity when you have a molecular progression, a low burden of this dominant close resistance. So look here, it's a totally different shape. There is an early clinical benefit when you treat ESR1 mutation and molecular progression. It's a very different shape. You see, within the 3 months, you immediately see a separation of the curves. I showed you before, in the first 3 months, you actually don't see any potential difference because most of the patients just don't benefit from the treatment. And very provocative, and we will understand better this data, the time to clinical significant deterioration improved significantly, statistically significant, but you see the effect is very early on. We don't know why, but you have an effect that is very early on in the first 3 months of treatment. So that is, again, a very big difference of what we observe with the Serena-6 compared to what has been described with Elacestrant given at progression. The third consideration that I want to share is, but which is the main idea behind moving camizestrant plus CDK at molecular progression? The idea is, if you target a small clone, you can potentially eradicate this clone and revert to sensitivity. You see the picture describe very well what I'm talking about. So you change from ESR1 mutation to ESR1 wild type. There are some indication that this happened with SERD. Yes, these are the data from Serena-2. Serena-2 was a phase 2 trial that demonstrated a statistically significant and clinically meaningful improvement of PFS of camizestrant compared to fulvestrant. It's a very clean design trial in metastatic setting. But look at this biomolecular marker. Look at the 2 arms with camizestrant and look at the fulvestrant arm on the right. You see that ctDNA ESR1 mutation does not disappear with fulvestrant, decrease, but was still there. Instead, look on the right. You see that many patients has a total disappearance, clearance of the SR1 mutation. This is suggesting that a much more potent SERM can really potentially clean up a situation where you have a not dominant clone with a very small disease. Does this have implication in SERENA-6? Yes. Look at the tail of the curves, not the first part, the last part. At 2 years is a long time, you have 29.7 patients free of progression in the camizestrant arm, and only 5.4% patient free of progression in the standard arm. That means that essentially this is the indication that there is a proportion of patients, 25%, 20%, doesn't matter, that really can derive a super long benefit if you target molecular progression. That's another thing that we will address more with longer follow-up. The benefit is present in all the clinical subgroup. The PFS2 we will discuss is not mature, but to me, PFS2 is not the most important endpoint, because I would like to see which is all the elements that I mentioned before, just stay on the benefit that we have in the first change of the treatment. What about the safety of the trial? The safety was very, very good. You see the rate of discontinuation for this drug is exactly the same, 1% of aromatase inhibitor. That is incredible well tolerated. And when you look at the adverse event, after making an exposure adjusted time, because of the longer exposure, you have some side effect like neutropenia that by chance, because the longer exposure can come more frequently. So after adjustment, it's exactly the same. There is no difference. And also, if you look at ocular toxicity, that it was a concern, really no patient have a significant concern about this side effect at this stage of the follow-up. What about the time of deterioration? I told you before, early clinical benefit we need to address, but very encouraging data. So my take-home message about SERENA-6, start with the weakness that I agree, the trial design. You know that Angela De Michele in the discussion really point out about the limitation of the design. I agree. So which is the major limitation? The major limitation is the trial is testing two things, not one. One is change in treatment at molecular progression. The second one is using camizestrant that target the acquired alteration at molecular progression. It's not just one of the two. So it's true that with this trial, it's not easy to separate the benefit of one and the other one. Before, I told you many reasons why we could speculate, why I believe there is an advantage for both the two strategies. And the second point is, if you just count the number of therapy, it's true that PFS1 include 2 drugs, but the standard definition of PFS is the line of therapy till the progression, not the number of lines. So, but if you count the number of lines, of course, it's true that the PFS2 in terms of number of lines, not in terms of line, because again, the line is counted as number of progression, first progression, second progression. But if you count the drug, it's true that there are 3 drugs. To me, again, that is not a major limitation, but tend to mix up a little bit the immediate interpretation of the trial. And the optimal timing of ctDNA, we don't know. But my personal take-home message is this is a positive trial that demonstrates that this adoptive therapy is efficacious. And I strongly believe, so it's my believing, so take it as they are, we can discuss, that mature trial results will really help us to overcome some trial design limitation and define the benefit of the strategy implementing camizestrant in this population. So if the drug will be available, in my opinion, I would apply this result because for sure are not worsening the outcome. And I believe that they already demonstrated a strong value with many indications, the control of disease, the delay of progression, the opportunity to give all the patients the drug, the long control in SANSA group, and the quality of life benefit. The last part of this presentation is a little bit coming to the post-CDK4/6 inhibitor target-driven selection. I told you when I mentioned this option that we would be back in this discussion. So the first thing, we know that we can target PI3K pathway alteration. Just to remind, PI3K pathway is not just PI3K mutation, also AKT1 activation mutation that are of the frequent 2.6% and 10 loss in activation, 3.8%. So around 10% of the group have this type of activation of PI3K pathway. The Capitello 291 trial is a trial testing fulvestrant plus placebo compared to capivacity. It is a AKT1 targeted drug plus fulvestrant. The trial lead to the approval by FDA and EMA only in the PI3K AKT1 10 altered group, which are the clinical results. Here are the results. A proportional risk reduction of progression of 50%, that to me is clinically and meaningful, and of course is statistically significant, very statistically significant. You know that the benefit is present in all these groups, so there is no way to select a patient that benefit or more. Liver metastasis, previous CDK4/6 inhibitor, and previous chemotherapy. Another strategy that we can apply after CDK is targeting. We mentioned before ESR1 mutation. These are the results from the Emerald trial. A very important table. So be careful here. When you look at the Emerald trial and look below, you look at ESR1 mutation, and you look at patients who progress within 6 months or between 6 to 12 months. Elacestrant, not the standard of care, has a median PFS that is 1.8 months, 1.9 months in 6 to 12 months. So there is no evidence that this group benefit in any way from elacestrant. So you should not offer elacestrant to a progression within the first 12 months of progression, with exception, but this should be exception. That's a totally different thing for capivacity, because capivacity overcome endocrine resistance because target PI3K. Elacestrant target a mutation that appears in endocrine sensitive tumor. So if you have early progression, probably it's not endocrine sensitive anymore. But anyway, come here. Primary resistance, secondary resistance, you see same benefit. So it's very different from capivacity because the proportion of benefit is the same. So you can also offer this drug for early progression. And this is another way to demonstrate that you should offer elacestrant only to patients who have a PFS longer than 12 months. You see 8.6 median PFS. That is good. That is a good result. So I would offer elacestrant to this patient. Still, you remember what I told you before. You have almost 70% of the patients that do not progress, or 30% progress, despite this very selective population. So take it not as a guideline, but my personal view. So what I usually do is when I have an aromatase inhibitor plus CDK, I look the time to progression. When I have a very short progression, I tend to favor chemotherapy or ADC. PARP inhibitors is BRCA mutated. Eventually, for some patients, fulvestrant and capi, no high burden of disease. So because we have evidence that it is working. Between 6 to 12, I strongly favor, compared to chemo and PARP inhibitor, another attempt with fulvestrant and capivasertib. More than 12 months, the two options available are elacestrant and fulvestrant capi. I tend to decide according to the burden of disease, how much is important the response rate. So I still tailoring about clinical consideration. What about the EMBER-3? Just very quickly, EMBER-3 has 3 arms: imlunestrant, that is a third, standard of care, fulvestrant or exemestane, and imlunestrant plus abemaciclib. These are the results that I didn't present before. You look on the right, these are patients with ESR1 mutation. What the curves tell us that imlunestrant plus abemaciclib, be careful, these are not all patients receiving a previous CDK. Most have received a previous CDK, but not all have received a previous CDK. But imlunestrant plus abemaciclib is better than imlunestrant. This actually suggests us that, of course, monoendocrine therapy, even when effective, the efficacy can be improved if you combine with other key, PI3K inhibitor, CDK4/6 inhibitor, new generation CDK4/6 inhibitor. One final consideration for you is we need to keep in mind that we don't treat disease, we treat patient. So we need to take in consideration not just the molecular biology, not just the clinical trial results, but the general context, including affordability of the drug. And probably the last point is, because we take in account the patient, we need to share our decision with the patient. So they need to decide with us, not alone, not just, I tell you the decision, decide what you want to do. We need to decide together. We need to help them to take in what is called a sharing decision. And I'm happy to come to the discussion and take questions if there are.
Thank you, Professor Bianchini. That was an excellent talk, showing us the way forward in case whenever patients progress on the CDK4/6 inhibitors. I have not seen any questions in the chat box, but I have 2 questions for you. The first one is, targeting molecular progression, do you think it is ready for prime time use?
So that is what I try to explain. So the trial design has some limitation. And we should recognize, even very good trials sometimes are not perfect trials. There is not a perfect trial design. One of the criticisms that Angela De Michele moved to the trial is there is no crossover. Careful, the word crossover should apply to treatment that are approved to be used. You cannot cross over in a trial with a drug that is investigational. There is no trial that offer to go for an investigational drug that is not approved for the indication. But of course, this doesn't allow really to state, okay, look, when you give camizestrant at progression, compared to giving camizestrant at molecular progression, is better to provide the drug at molecular progression. So with this limitation, of course, there is interpretation. My personal point is, look at the graph in an honest way. So despite all the limitation, look at the long-term benefit of, we are talking about 29% of patients free of progression at 2 years. How much is possible when you have a clinical progression that at 2 years you have 1 out of 3 patients, almost 1 out of 3, that is free of progression? It's impossible. I've never seen so long response with elachestan in metastatic setting. The second element that is very important is the fact that you can really give the drug to all the patients. All the patients can receive the drug because molecular progression are patients that are doing clinically well. Maybe they start to have some baby pain, a little bit of symptoms, but that means the imaging saying no change. You should not change the drug. So you can really offer this drug to everyone. That's another advantage, because I know that if I wait the clinical progression, some patients need chemo. So I will lose this patient to this therapeutic option. That's another, to me, clear advantage. The other thing is, look at the graph that show the early benefit in quality of life. Why? Why you have in a randomized trial with placebo, is with placebo, a so large difference in the early quality of life? That means that probably the patient that receive an effective treatment benefit, maybe they have a little bit of symptoms that decrease. Probably at ESMO we will have more data, but I cannot, I would say, discuss anything that is confidential. The point is, I will really think this is a strong indication. So all these things make me to say, everything is free so far to interpret the data. I believe that for me, if available and reimbursed in Italy, because without reimbursement it's very tough in Italy. So if reimbursed, and also reimburse the test, because in Italy we have also a problem for the reimbursement of ESR1 mutation. But imagine that I have these two situations where the test is reimbursed, the drug is available, I will use it. So for me, is already it's ready for prime time. But that is my personal consideration.
And the second question is that those patients who might harbor both the mutations, that means ESR1 and PIK3CA, at the same time, when you look for them, which one would you choose to target first?
So that's a very good question. I would like to start with another advantage of SERENA-6. You know, we don't have trials that say at molecular progression of ESR1, you should use a PI3K inhibitor. No, we don't have data. So if you use at that time camizestrant, if they are co-mutated at progression, you can use a PI3K. You don't have to choose because you have already used the third. So that is the first advantage for SERENA-6 perspective. Imagine that you don't have SERENA-6. So you are in the standard treatment, the patient have received ribociclib and letrozole. You have a progression, you test the patient at progression, and you have ctDNA analysis positive for ESR1 and PI3K mutation. Should I give fulvestrant plus capivasertib? Alpelisib is not available in this situation. I can also tell you that the safety profile of capivasertib is much better than the safety profile of alpelisib. So because I do not believe that I have evidence that suggests that capivasertib is less effective, actually it seems even more effective, but it's for sure not less effective. Capivasertib will be the best target. So on one side, I could decide to go for fulvestrant plus capivasertib. On the other side, I can choose elachestan. So how to choose? I mentioned you before. If I have a progression within the first 12 months, so this is an endocrine resistant, technically, according to the last ESMO guideline, when you have a progression under CDK, 12 months is the definition for primary endocrine tumor. All of you remember that in the past, primary resistant tumor was progression within 6 months of monotherapy. But for the combination, was proposed to prolong this definition, 12 months. So this primary resistant tumor do not benefit for elachestan. So elachestan for me is really not an option. So the two are the option. Capivasertib plus fulvestrant or chemotherapy or PARP inhibitor. If the progression is with a duration of treatment longer than 12 months, I usually tend to decide according to the burden of disease. Even if I have visceral disease, but I'm not worried, I prefer to use elacestrant before, because the tolerability is extremely good. It's like using letrozole, fulvestrant, so it's very well tolerated. But the first TC scan is after 6 weeks. Because I have this drop, I want to capture the patient that don't benefit at all. When I see that there is no progression very early on, I start the assessment every 3 months, as we usually do in clinical practice in metastatic setting. On the opposite, if I have concern, but not to go for chemo, and I want to use a drug that with the higher response rate, just to remind that the response rate of capivasertib and fulvestrant was 25%. So a good response rate in that specific setting is comparable to many monochemotherapy. I would prefer to use capivasertib and fulvestrant. And eventually, if I reduce the burden of disease, using elacestrant later. So these are the clinical driver of my decision.
Yeah. Thank you, Professor, for that excellent presentation.
Ma'am, can we
excuse
take
me?
some questions as well?
Yeah. So
Yeah, from the each center as well.
yeah. So any centers? Yeah, please go ahead.
Yes, Dr. Palak this side from Ahmedabad. I would like to ask one question. If ESR mutation is there and patient having HER2+1, then TDXD versus Serena-6, what should be the preferable choice in practical scenario? And how should we go in that case?
So just to stay to what the Serena-6 population enrolled. Serena-6 population enrolled patient that was after 2 lines of endocrine therapy, not 1 line, after 2 lines, if progression is beyond 6 months. So all the patients that enter in Serena-6 have to have received 2 lines of endocrine therapy, not 1. So that means that you have to give elacestrant or capivasertib. Otherwise, in Italy, it's not reimbursed. Even when we will have DB06, they will follow the trial design. The trial design is you need to have 2 lines of endocrine therapy. Of course, this is different if you have an insured patient and you can freely decide. In this case, my decision is very high burden of disease, and what I told you before, no? Very high burden of disease. I need a treatment that works very fast and better. I would choose trastuzumab deruxtecan. I have even a visceral disease, but I'm not forced, for this decision. I would probably stay on the endocrine therapy line. Also remind that, imagine that you have a patient with a very high burden of disease, and you don't feel safe to give elacestrant or capivasertib and fulvestrant. You give trastuzumab deruxtecan, and as frequently happens, you have an excellent response. You reduce a lot the burden of disease. When you have a clinical progression, probably you have much less disease. Then, in indication, you can give either elacestrant or capivasertib. So we have some patients that receive TDXD, like in private setting, and after that receive elacestrant and capivasertib, actually with very, very good PFS control. So that is something that you need to consider. The final point is to remind is that I mentioned before, when you have a progression within 6 months, so very, very endocrine resistant, I told you before, in general, I prefer chemo if it's not BRCA mutated. That means if TDXT is available, I prefer TDXT. So, of course, that's why in my slide I put ADC, because if available, trastuzumab deruxtecan is by far much more effective.
Thank you.
So, any more questions from?
Ma'am, we are from the Hyderabad Center as well.
Yeah.
Hello, madam. Good evening. This is Dr. Santosh from Hyderabad. Thank you, sir. It was a fantastic lecture. I have one or two questions, sir. So, I want to know in the Serena trial, the control arm, what portion of them have received camizestrant after progression? That is the first question. And was there actual crossover or allowed at progression, or what this information gives us, whether we use in the second line will have the ultimate endpoint of overall survival? So this is my first question. The second question is, in one of the slide you have showed different types of mutations, different drugs are sensitive. One of the mutations is even resistant to camizestrant. That's what I have seen. Is it like chronic myeloid leukemia space, where we do mutation analysis and choose a drug across various available options like imlunestrant or camizestrant or elacestrant? That is the second question.
So I get very well the first question because your microphone doesn't work extremely well. So the first question is really related to, you know, the crossover, or the fact that it's normal that one asks, you know, but which is the advantage compared to giving the drug after that, and eventually the impact in overall survival? So I would repeat some of the concept, but the first very important thing to remember to all of you, elacestrant do not improve overall survival. So just to remind, have you ever seen any data that suggests that elacestrant improve overall survival? And the answer is no. But the reason why you haven't seen benefit in overall survival is because the drug do not provide overall survival. Okay, so because otherwise, you know, the company don't keep secret something that is very important for them. So again, that doesn't mean that I don't want to use elacestrant. It's just to say, to be fair, that is not the point of overall survival, because otherwise you used to say, I don't use elacestrant because this drug does not improve overall survival. We use elacestrant despite there is not a demonstration of benefit in overall survival. Why there is not a demonstration of benefit in overall survival? For many reasons. One is very small sample size. We see the Monarch 3. Monarch 3 is a trial in which we have 13 months in improvement in the median overall survival, but the p-value is 0.065. And there are 600 patients enrolled. In this trial, the number of patients is close to, so the Serena 6, you remember how much are the patients randomized? Is 300 all the trial. So these trials are strongly underpowered to detect an overall survival benefit. The other thing is, you know, try to think, I'm a patient. You know, when I treat my patient as an exercise, I will say also philosophical exercise. Sometimes I come home and say, imagine that I am the patient that I treat today. Is progression just, oh, there, progression, that's it? Or progression is something that hit my life? Progression, first progression, hit life. You know, you come to have a metastatic tumor, and probably when you describe the patient that can afford, because I know that in India, not all the patients can afford the effective drug. But when you have a patient that can afford the treatment, and you offer a CDK4/6 inhibitor plus aromatase inhibitor, you say, oh, this is a very good option. We have very good control of disease. And imagine that this patient stay very well, very good quality of life, and after 2 years, no symptoms. The TC scan show almost a complete response. She feel like I don't have a disease till she have a progression. When she had a progression, it's like taking the patient, putting the patient on the floor and say, oh, look, you will die by your cancer because you see this progression, other progression will come. So delay of the first progression is an incredible important thing for patient, not just for doctor. And that is something that is sometimes underestimated by physician. So as I told you before, the trial as it's designed is not able to directly answer your question. So could I have this have the same result? To come to your question, the crossover means the same drug given after was not in the trial. But the reason is you cannot offer a crossover to a drug that is not on the market, is not approved. So why you should offer a crossover? But the Lachestan is used for a proportion of patients. And of course, the post-treatment is recorded in the trial. Actually, very well recorded because PFS2 is one of the major endpoint of the trial, is a principal secondary endpoint. So that means that there is a lot of emphasis in collecting the information of what happened after the treatment. So to come also to part of your question, if we will have information about the post-treatment, so we already have, and we will have even more in the future because this trial again put a lot of emphasis on what happened at progression. But to come really close to your question, we will never have the certainty that if you give the same drug after will be the same. But to me is, I already see the benefit because I told you after progression, look at your chart, just play with the data and look how many times in my hospital, in your hospital, you give chemo after progression to CDK. All these patients would not receive a Lachestan, and that's not because of money. In our country, the drug is given for free by the national system. So it's not a matter of money. So my colleagues, the 40–50% of colleagues that use chemo is because they don't feel comfortable to give a drug in which the response rate is 8%. So the Emerald trial show only 8% response rate. So it's a good track for a control of disease. It's not a good track for reversing like symptomatic disease. The first point, sorry, but because of the microphone, I know that was referring to the multiple option and the identification of the molecular heterogeneity, but I really didn't get the answer.
So could you repeat that question?
ESR1 mutation, can we choose the drug? Type of ESR1 mutation?
So now I listen to the guy. So you ask me if we choose the drug, which drug?
Yes.
We have multiple types of ESR1 mutation.
Oh yeah, okay.
So, which drug we choose, because one particular type of mutation, even chemicistrin was resistant. You showed in one of the slides.
Yeah. So there are now everything is clear. So let me go in deep of these observations. So what the college is asking, just to is understandable for everyone, is ESR1 mutation as a unique biology. So there are hotspots, but different hotspots. So the question is, does this hotspot have the same sensitivity to oral cell And so can you just say ESR1 mutation, or you should clarify what type of mutation you have? That's the first question. But I would add another one, that ESR1 mutation is usually polyclonal. PI3K mutation is monoclonal. So that's me. If I look for PI3K, I usually find one mutation of PI3K. It's very rare. Sometimes you find two mutations. It's very rare. For ESR1 mutation, frequently, you find more mutation. The reason is because start from small clones. It's possible that, like, in one lesion, emerge one clone. Another region of the tumor emerge another new clone. So you can have within the same tumor even sometimes 4 or 5 different ESR1 mutations. So I come to two questions. Is first, does the activity of ESR1, so of SERD, be more or less when you have multiple ESR1 mutations? The second is, do we have any clear evidence that there is a mutation in which SERD are not effective? The first question about multiple mutation is, it doesn't seem to be a strong predictive biomarker in terms of efficacy. It is more a prognostic. So, like if you have one ESR1 mutation, or if you have multiple ESR1 mutation, the risk of die, so really the prognostic is worsening for the one that have more mutation, because probably tell us that the tumor is generating mutation. But is not predictive of benefit for ESR1. For instance, there are data generated in MRR that suggest this thing. In SERENA-6 is planned an analysis, very deep analysis for the biomarker, to really also answer the question in SERENA-6. Does the benefit different in these two populations? We still don't have the data. Even in the steering committee, maybe the analysis really have not been done, because we are waiting for having a more robust clinical readout with the main PFS to have more event and a more powerful study for this MORSA group. Coming to your question about this MORSA group, it seems that there is one of the alterations that potentially could drive less activity, but I just caveat the fact that when you have a forest plot, in general, not just for ESR1 mutation, you have to be careful when you just have one that like cross one or is close to one, doesn't tell you that the result is one, because you need to look at the interval confidence. So we ask actually this, and we suggest to have the test of interaction within the figure. But you know, when we have the publication, the analysis was already done. But the point is, the test of interaction has been done as is negative. So that means that at this stage, we cannot claim a different activity according to the mutation. But there is a strong intention to do this type of analysis. And also, you know, Bidardi is one of the two chairs of the SERENA-6. There is the intention to really combine information from PADA and SERENA-6 to really have more molecular information about the relevance of the single subgroup. So at this stage, I would say it's too early to say the drug is not working in this group, but you point a very, very, very important element that we want to address. Also, Nick Tanne is strongly interested, but all the steering committee member and also AstraZeneca is really interested to develop more of precision medicine. And potentially, of course, if we will have robust data that suggests that there is a group that will not benefit, that will be declared, shared, whatever. But at this stage, I will really take this data with a caveat.
Thank you.
Yeah, so thank you for that very interesting discussion and the questions. And now we can move on to the.
I have a question. Sorry
Yes.
to interrupt, ma'am.
Okay.
I have a question. So, Professor, any experience with ESR1 fusion? Because in our cases, we also had fusion. So, since you
Yeah.
had many cases.
Yeah,
amplification.
you know the first of all, for all that are not maybe for you that are more familiar with, but ER fusion exists. So I would say I would not be surprised that in the future we will talk about two new subtype in breast cancer. One is ESR1 amplification. So sometimes ESR1 is amplified. And amplification of estrogen receptor genes seems to be clinically relevant. So maybe in the future, there will be a new breast cancer subtype within ER positive. And one are the estrogen receptor fusion. And actually, this has already been demonstrated. I don't remember when it was published, but there was a very nice preclinical study that really demonstrate that the most common find fusion. You know, the fusion are not random. You almost always you find like estrogen receptor bind with another gene. Honestly, now I don't remember the name of the gene because it's not a famous gene. Is a biological gene that usually you say, who?
We had some CC, I think.
Yeah, but that's not a gene that you say, okay, I know this gene is a famous gene. No, it's not a famous. But
it's not.
The point is, this preclinical study demonstrate that these fusion genes activate the signal in a very potent way. So this is probably a mechanism of say autonomous activation of the estrogen receptor pathway. So why we don't detect so much? Because depends what method you use to assess ESR1. Because if you look up amplicon for hotspot, it's very unlikely that you have a detection of something that is really different. The second one is you do probably also tissue analysis, not just blood, or you detect in the blood.
So we had both, like they are not the same patients. There were, I think, 7 patients for tissue. We picked up in the tissue.
Because
blood
just for all of you also in lung cancer and so on, translocation and the translocated gene are easily to be identified in the mRNA space. So like if you look at the foundation one, merge some DNA assessment, but for fusion gene, they have more assessment also in mRNA because increase the sensitivity. But anyway, these are activating alteration. We of course we still don't know which is the best way to target this alteration and the clinical implication that they have in terms of treatment selection. But I'm sure it's not frequent, but this is going to be a very rare subgroup in breast cancer. It probably will have a specific drug or inhibitor. So I think they are very, very interesting.
Sir, I'm so sorry to interrupt you, sir. We'll have to move on to the panel discussion as we've overshortened the time. We can probably take the questions offline if that's okay, sir.
Okay. So now we move on to the next part, and that is the panel discussions. So I call upon Dr. Jyoti Wadhwa. She's the lead medical oncologist on precision oncology at Apollo Cancer Center, New Delhi. So I invite her to call the various panelists and to discuss the cases. Dr. Jyoti Wadhwa.
Thank you, Dr. Smruti. And so we are going to have 3 case presentations, and we have also the experts joining in from 3 cities, Delhi, Hyderabad, and Ahmedabad. So let me immediately invite the first case presenter. That's Dr. Mounika Boppana. Over to you from Hyderabad. And I request Professor Bianchini and Dr. Moushumi to stay back for their inputs.
Ma'am, there's a slight change. We'll start with Ahmedabad with Dr. Rushabh Kothari, ma'am.
Okay, please go ahead.
I think I have sent the slide, so can you show it on the screen?
Sir, I
Kashish,
think it
from
can
your
be
side?
shown at the center, sir.
Okay.
These are the slides, Sir AstraZeneca. Sir, have you shared the slides separately as well?
No, that is the same. So
Okay, I'll just share this, sir.
okay, okay. Yeah. So we have 42-year-old female diagnosed in 2013 with CA right breast, T2N1, hormone positive, ERPR positive, and HER2 negative. Treatment was surgery followed by 4 cycles of EC, followed by 4 cycles of paclitaxel, followed by locoregional radiation with adjuvant tamoxifen, and then it was changed to anastrozole with leuprolide because there was endometrial hyperplasia and patient was symptomatic for it. So this 5 years of endocrine therapy was completed in 2018. Next slide, please. In 2021, patient had bone metastasis. And again, it was biopsied and it was ERPR positive, HER2 negative. Patient was started on CDK4/6 inhibitor plus letrozole and zoledronic acid. Patient had good response, almost CMR on PET scan. And patient continued to have maintained response till 2023, when patient again started having pelvic bone pains and there was increase in FDG avidity. All the lesions were sclerotic prior and palliative radiation was planned. And at this point of time, germline testing was also done, but was negative. Next slide, please. So after this, patient had some partial response, but in short time, patients had liver lesion and new bone lesions. It was biopsied again. It was ER strong positive, PR mild positive, and HER2 1+. NGS was done. There was ESR1 mutation with a good VEF. Patient was started on gemcitabine plus carboplatin as PFS was very small and 4 cycles were given and there was progression. And then patient was shifted to TDXD NHER2 with zoledronic acid and patient had response, and currently patient is responding to this line of treatment. Next slide, please. I think the case is over. This is the NGS report. Next slide, please. Yeah. I think this is the last slide. So patient is on TDXD for HER2 low ER positive after 3 lines of hormonal treatment. And there is patient has a response and is on this treatment at this point of time. Next slide, please. Yeah, so this is just for discussion. So we don't have access to oral SERDs as of now. So if we had access to all these drugs, would we have done anything different? That is the only question which probably we need to answer once we have access to all these drugs.
Yeah, so thank you, Dr. Rushabh. And let's hear from Professor Bianchini. So in a case like this, as he rightly pointed out, if we had the oral SERDs available to us in a case like this, wherein we did detect ESR1 mutation and the patient has HER2 low metastatic breast cancer, has failed multiple lines of treatment before, what would you do? I think you briefly did touch upon this aspect in response to a question raised earlier, but what would you do in such a case? And are you happy with the way this case that he presented was managed in absence of availability of oral SERD?
You know, is interesting because actually you don't realize that in this case, you try to use a Padawan approach. Because what you do when you have a very modest clinical progression, you can call molecular progression, doesn't matter. You didn't change the treatment. You keep ribociclib and you keep fulvestrant. So I tell you, that means that you already believe in SERENA-6. Because, of course, if you would have been camizestrant is better than fulvestrant. At that time, you would have had a ESR1 mutation detection because you would have done a ESR1 mutation. That's perfect. So you prove that in the mind of oncology, they already believe in the Padawan and they already believe in the SERENA-6. Exactly, you do the Padawan. So you consider this a minor progression. Just a little bit of point. The first, don't take it as wrong, but as attitude, always when you present cases, never write anymore HER2 negative. Always write HER2 0, 1 plus, 2 plus, and actually even train your brain to write HER2 ultra low, HER2 null, HER2 1 plus, HER2 2 plus, or HER2 positive, and say 2 plus fish amplify or 3 plus. So we really need to start really change also in the previous block. And if you understand that you don't have this information, ask your pathology, can you revise this block? Anyway, the second point is probably when you have a very modest clinical progression, you change to fulvestrant, we would have changed also to abemaciclib. So the post-MONARCH trial demonstrate that abemaciclib plus fulvestrant at clinical progression, so also a small progression, is probably the best way to go. It's true that you have also the maintain data, but the maintain come from a phase 2 trial, as not, I would say, is an investigator-initiative trial, and the quality of the data are not as strong as a phase 3 dedicated trial with all the quality assessment of a company-sponsored trial. So, and I also believe that ribo is not equal to abemaciclib. So I would like to change both. Come to the clinical progression. According to your description, I didn't see any reason to consider this a visceral crisis. So I would have probably preferred to use ESR1. But in my experience, many doctors would have gone for chemo. That is another example why it's better if you really offer ESR1 targeted drug like camizestrant at molecular progression. Because otherwise, when you have a serious clinical progression, you prefer to go for chemo.
Right.
But the management was very good. Actually, again, you was very far to apply the Padawan approach even maybe before the PADA1, because I understand you did this change in the time, maybe it was already just released the PADA1 results or something like that.
Just one question to you, Dr. Rushabh. Did you do a rebiopsy?
Yes,
Rebiopsy to look at the HER2 new status or?
yes, rebiopsy was done at progression initially when there was bone only progression, and then it was done again also.
Okay, all right. And Dr. Moushumi, if I could ask you, he did show the ESR1 mutation type. So any comments on that? The type of ESR1 mutation, we know it's prognostic, but would it in any way affect the, treatment decision making?
So one thing is that it was in the ligand binding domain, which is the common domain. Another thing is the VAF. So what I have understood through the study, so you don't have to give, the VAF doesn't matter. So it has to be, it is present or absent. So for now, this is what is there, because the VAF will be there and you can have co-mutations, fusions, amplification. If we start doing these NGS and biopsies, we will find a lot of things. So this is what we know so far.
Right. And just last question to you on this case, Professor Bianchini. So suppose we are monitoring ESR1 mutations every 3 monthly or so, starting from that 6 month to 30 months period. And if we see that Dr. Moushumi said, don't look at the VAF, or if we see that the levels are static or, they are not increasing versus when they start rising.
You know, is a different. So it's different compared to like monitoring PI3K mutation. If you are monitoring PI3K mutation, the point is, I see a PI3K mutation, maybe it decreases without disappearance. I follow the mutation because I use this as a liquid biopsy registry. You remember the paper that I mentioned?
Yeah.
But for ESR1 is a different thing. You are giving not the second treatment, an aromatase inhibitor and a CDK. If you detect a ESR1 mutation, an aromatase inhibitor is totally meaningless. It's like stop the aromatase inhibitor and just give ribociclib as monotherapy. We know that CDK4/6 inhibitor as monotherapy doesn't work. So for ESR1, you don't need to have an increase, a decrease. If you detect ESR1 mutation at 6 months, you treat the patient. So that means that if you don't treat the patient with camizestrant, it's because it's negative. So no VAF is negative. And so is the appearance that happened. So just to remind all of you in Serena 6, that's what happened.
Right.
If you have a detection, doesn't matter the VAF. It was just mentioned. You have 1%, you treat the patient with camizestrant. If it's negative, you follow the patient.
Right.
When become positive is an increase, because by definition, negative become positive. And you treat the patient.
Right. Thank you. Any questions from Delhi or Hyderabad Center? Or anybody from Ahmedabad itself? Any questions for the experts? If none, let's move on. And Kashish, you could invite the next case presenter.
Yes, ma'am. I now invite Dr. Mounika Boppana from Hyderabad to please present a case. She's a consultant, Department of Medical and Hemato-Oncology at KIMS, Secunderabad. Over to ma'am.
Everyone. So here I present a case of a a 47-year-old homemaker with no comorbidities. She was perimenopausal when she was initially diagnosed with a non-metastatic grade 2 invasive carcinoma in her right breast. So she was treated with a curative intent in the year 2015. And she was diagnosed then. She was strongly ERPR positive. HER2 was negative. So she underwent surgery upfront, and it was a T1N0 disease. She was not offered any recurrence risk score estimation at that point of time, and she was put on tamoxifen till 2020, and she stopped at 5 years. So stopped thereafter. The reason is unclear. In about 3 years after stopping tamoxifen, she complained of bone pains of about 55 years, and she was menopausal by then. On evaluation, there were multiple bone metastases. So a repeat biopsy was done from the soft tissue component of one of the vertebral metastatic lesions, and it was still found to be strongly ERPR positive, and HER2 was negative. It was 0. So she was started on letrozole and ribociclib along with 3-monthly bone modifying agent in September 2023. We had an excellent response on subsequent scans, which were done at 4-monthly intervals. And she did well for nearly 18 months. And in July 2025, her PET showed a progressive disease in the form of new liver lesions. There were 3 new liver lesions. So there was an obvious and overt progression. So at that point of time, a liquid biopsy was done, and that showed the ESR1 mutation, the Y537S variant, and a PIK3CA mutation was also present. So she's started on fulvestrant with alpelisib from July 2025. She's tolerating reasonably well. She's a non-diabetic, and her sugars also have not been difficult to manage. She's been tolerating well so far, and she's due for her first response assessment in October, about 3 months from starting this regimen. So I have 2 questions, not exactly pertaining to this case, but many times we find patients who have a single site recurrence while they are on aromatase inhibitors. So when they have a recurrence while on aromatase inhibitors, and we do liquid biopsy at that point of time, it's a single site recurrence amenable for local treatment, like for example, just a chest wall recurrence. And the patient has been on aromatase inhibitors for 3 to 4 years and has a single chest wall recurrence, treated with local treatment. And at the same time, we send liquid biopsy to assess why there is a recurrence on AI. And if we find ESR1 mutation, post this local treatment in adjuvant setting, what endocrine therapy continuation can we offer to such patients? Because don't have data for giving investment in this setting where there is a single site recurrence and it is taken care of locally. There is no other metastatic site. So are we still justified in using drugs like fulvestrant with or without ESR1 mutation? That is one question that I wanted to ask.
Yeah, so let's hear from you, Professor Bianchini, first.
So the short answer is yes, absolutely yes. And the reason is the following one. In clinical trial, we are forced to ask for having measurable disease. So we need to have a lesion because we need to provide the richest criteria of response. But if you are metastatic, whatever it is, lymph nodes in the mediastinal site, liver lesion, or whatever, and you have one lesion and you decide to treat this lesion, the patient is still metastatic. It's not because you remove the lesion, the patient is not metastatic anymore. We call not evidence of disease metastatic patient. So, and is worth it to give a treatment? Absolutely, yes, I would say. But I would say, I would like to struggle to change a little bit your question, make it more tricky. Imagine your patient, a lot of bone disease. She responds very, very well. And she have 2 lesions in the liver. So it's simple to think. The question is this an oligoprogression? It's a way, yes, because maybe you can treat locally the lesion and you can say, I continue the CDK4/6 inhibitor plus the same endocrine therapy, okay? We do this in Italy many big centers to this type of approach. So oligometastatic mean non-patient oligometastatic that become oligoprogressive. Patients who are broadly metastatic with oligoprogression. That means that the bulk of the disease is under control. So my point is, think again at SERENA-6. Think at molecular progression. Imagine that you are free of money, you can do what is best for the patient, doesn't matter. Of course, would make much more sense when you have a oligoprogression to look at ESR1 mutation and not continuing an aromatase inhibitor if there is a ESR1 mutation, but giving like camizestrant and continuing the CDK4/6 inhibitor, because that's exactly the best application again of the SERENA-6 concept. But you're totally right. We also consider to add local treatment. There is no reason not to treat the patient in which you do local treatment. You make the patient net, doesn't matter. You need to treat this patient as you haven't removed the lesion. So you have to give the best treatment for sure. I would not wait and look at. It's very different brain lesion in HER2 positive disease, because in this case, we have a single progression in the brain. We treat the lesion in the brain. The patient is not receiving nothing. And now the standard is not giving nothing, but is in the brain. Because no one has demonstrated that in this case, especially in a patient that is treated like with a gamma knife, you need to add anything more. But outside the brain is a different thing, because this is a demonstration that you probably have micrometastatic disease, and you need to treat the disease to avoid other lesions become microscopic.
Right. Dr. Pankaj, your inputs on this, such oligometastatic disease, how would you approach? Not audible.
Am I audible?
Yes.
Yeah, so I totally agree with Professor, because many times we have this oligo progression. There's a lot of disease and one or two sites are progressing. And many times it's actually the breast if the patient has not been operated before. So at times we do go ahead with the surgery or radiation, some site of the type of local therapy, and we add to maybe 6 to 9 months of PFS to these patients, and which is good enough reason to why to add this. But again, when we have these tests available and these drugs freely available, I think this we might change the therapy. Only thing is, I might just give local therapy also the oligoprogression. In addition, I can change to the SERDs. So maybe I'm buying more time before we switch on to chemotherapy, because the quality of life will deteriorate after we put the patient on chemotherapy.
Right. Dr. Sunil, your inputs for oligoprogression?
Yes, I agree with Dr. Pankaj what he has said. That
So you would offer local treatment and you would also change the systemic treatment, right?
yes.
Yeah. Any other questions for the experts?
Ma'am, one last question I
Yeah.
have. In the same case which I presented, because we don't have access to oral SERD, so although knowing that fulvestran's activity is not that great in ESR1 mutated tumors, we had to put the patient on fulvestrant. But suppose at 3 months there is a progressive disease, what is the take on adding camizestrant or oral SERD once we have access? Suppose we have access 3-4 months down the line. Post progression on fulvestrant, does it make sense to add camizestrant at that point of time while continuing the CDK4/6 inhibitors?
Yes. To me, the short answer is yes, because we have robust data that describe that the SERD, the oral potent SERD, can work after progression to the old SERD fulvestrant. This is much less powerful, and especially if you also have CDK4/6 inhibitor as a backbone, because they can still interact if you are more powerful to target the alteration. So yes, I will I will offer this opportunity.
Thank you, Professor.
Right. So let's move on. And Kashish, please call upon the third case presenter.
Yes, ma'am. Thank you so much. We'll call on to the third case presenter. It's Dr. Santosh Kumar Chellapuram. He's a senior consultant, medical oncology, hemato-oncology, and BMT specialist at Star Hospitals, Hyderabad. With that, I will hand over the mic to Santosh, sir. Over to you, sir.
Thank you, ma'am, for the opportunity. So I would start my case by paying homages to Doyen of Pathology. We lost Madam. When I moved out of institute, Madam was helping in difficult cases. She used to predict the clinical features based on this one. So we dearly miss Madam in this era. I think her loss is unsurmountable. So with this, let's start my presentation. So I would present a case of a very interesting thing which gave long PFS with the initial CDK4/6 and later progressed. I thought this slide is very bland, so I would use some AI. So it has created an image like this. So I told that create an Indian context and I am a male. It created like this. And finally, I had an image like this. So yes, we know the ESR1 mutation leads to resistance. As discussed, 20 to 40% mutations we see. Coming to the case here, she's a 73-year-old lady. She presented with upfront metastatic breast cancer with bone-only metastasis, strong ERPR positive. So at this juncture, she received treatment with palbociclib plus aromatase inhibitor. So she was started on this. After the initial assessment of 4 months, she had complete response with this combination. My slides are not moving.
Kashish, are you displaying them yourself, Dr. Santosh?
Yeah, I'm using it as slide advancer.
Kashish, could you play from your end?
Sure, ma'am. I'll just do that.
Yeah.
I have my presentation here. No?
Oh, you have modified and improved upon. Yeah, now it's moving.
So the baseline diagnosis was in November 2021. So she was started on palbociclib plus anastrozole. After initial assessment, she was in complete remission. Every 6 months, she underwent a PET scan. She had a PFS of 40 months. Now, we had done a PET scan that showed progression in the liver and in the bone. So after 40 months, in January 2025, she had progression with visceral disease, liver metastasis, along with bone metastasis. Biopsy reconfirmed the ERPR status, and the liquid biopsy by Foundation 1 has been done, showing ESR1 mutation along with ERBB3 mutation. So this is the profile of the patient where she had long PFS. So at this point of time, I explained the patient, oral certs are not available in India. So she traveled to US and she was initiated on LSS trend. So she is on LSS trend. The first assessment showed very good response. So based on this particular slide, the questions that came to my mind are, the first is, we have seen the prior case also having visceral disease in the liver. So we have seen in the professor's discussion that this hepatotrophism is possibly a feature of ESR1 mutation. That is one thing. And such long PFS, does it have anything good response to subsequent oral certs? That is the second question I have. I think with this, I would end my presentation and I would seek inputs from the experts.
Yeah, Professor Bianchini, I think very important questions he has raised.
So, at the end, the decision was very good, and that demonstrates that offering a third we have patients that have this endocrine sensitive tumor. Actually, these patients also have several NF1 alteration that is also a typical acquired mutation to endocrine therapy, indicating that the tumor start to acquire alteration to drive independence. If you come back to the, you see NF1 variants, multiple low FAF, because it's typical, it's like SR1 mutation. It's typical that you have a subclonal alteration. RB1 is an indicator that is a mechanism of resistance to CDK, so I will not insist with a CDK. There are some data that suggest a lower activity for CDK. That is a perfect selection. So what to do after that? Of course, I don't see any other druggable alteration. I also would mention, be careful in your presentation of the case that you still are talking about HER2 negative in general disease. Is very important. Or again, is an exercise. I even when with my colleagues, when they report to me the cases, now they know, because every time I say, please don't say HER2 negative. Tell me if it's 0, ultra low, actually null, ultra low, HER2 1 plus, HER2 2 plus. That was a good decision. So also MDM2 amplification is also associated with endocrine resistance, just to be sure. So there are several that are related to endocrine resistance. RB1 is more related to that one. So my personal idea is I would give, if it is 1 plus 2 plus, and you have the B09 option, best option at progression, trastuzumab deruxtecan. Be careful about HER3, because that is not expression, that is mutation of HER3. And we don't have data that connect HER3 mutation and patritumab deruxtecan activity. On top of that, is not, I would say, available on the market. But I would say I don't see any reason, if it's 1 plus 2 plus or ultra low, to not offering TDXT and try to give patritumab deruxtecan. So again, if you have affordability and you have 1 plus 2 plus ultra low, best option at progression to elachestan, trastuzumab deruxtecan. And I will not go and look for even enrollment in clinical trials. So far, there are no clinical trials that offer anything best of this.
Thank you, Professor. Thank you.
Any inputs from the other experts from other centers, Delhi center? Anybody else? Any more questions? So this patient did have multiple alterations, and the presence of so many alterations in a single patient, I think there must be some effect. So Professor, suppose this patient now progresses on elacestrant and you treat then on next progression with TDXD, and then the progression on TDXD happens or toxicity happens, then what next? You would obviously be repeating again, but suppose the alterations are similar to what we have on the screen.
So just to, so even MDM2 amplified, there are drugs that are on phase 1 development. The first result doesn't seem to be impressive. It's very, MDM2, just to remind to all of you, is very important biologically, bind to P53. So is like targeting P53. It would be a dream, but it's very, very hard to target these tumor. for RBB3, again, we have trial, but we don't have a demonstration that mutation in RBB3 drive a higher sensitivity of ADC targeting RBB3. It's not like for HER2. We have an indication that if you have HER2 mutation, drug targeting is interesting. Not just HER2, but also HER3 are more effective. And so I would go probably for capecitabine of a taxane. You know, this patient in particular had never received a chemo in her life because it was a de novo disease. But he's quite old because it was like 75 years old, if I remember, or something like that. So probably a progression to DDC, I would offer capecitabine. DP06 actually showed that capecitabine performed very similarly, numerically better than taxane. So using capecitabine is absolutely acceptable. Probably there is another consideration. You're right. You point out that these patients have several alterations. You know, it would be very, very, very interesting to have the initial biopsy and look how many of these alterations was there. Because there is another reason why Serena-6 makes sense. So when you have a tumor that is responding very well, the burden is very small. So less likely generate molecular alteration because molecular alteration are a stochastic phenomenon. If you have a lot of cell, more probability that you have mutation. If you have less cell, less probability. So what happens when you have a ESR1 mutation? Several times these allow to acquire additional mutation. But if you target the molecular alteration like the Serena-6 and you eliminate the clone that has the potential to acquire additional alteration, you target a more stupid tumor. And again, these respond well to a large extent. But my question is, would this patient maybe stay on treatment for like 3 years, 4 years, if you target the molecular alteration and appearance? So I would say Serena-6 will tell us with longer follow-up, but that is an additional advantage to using the Serena-6 approach to avoid the acquisition of additional molecular alteration on top of ESR1 when ESR1 clone can freely grow.
Thank you, sir.
Right. Thank you very much. So if there are no more questions, I would hand over to Kashish.
Thank you so much, ma'am. With that, I would request our program director to please give her closing remarks. Over to Smruti, ma'am.
Yeah. So thank you one and all. First of all, AstraZeneca for giving us this opportunity to, really discuss threadbare, how to deal with endocrine resistance. I would really like to thank Professor for his excellent presentation and also the really good discussions that we have had with all the 3 cases. And we have really understood how to target these mutations that appear when there is resistance to the CDK4/6 inhibitors. I would also like to thank Dr. Jyoti Wadhwa and all the presenters for their excellent presentations. And I think we've learned a lot about how to deal with these mutations when they do come up to cause endocrine resistance. And I think with this few remarks, I would like to close the session and thank everybody and also AstraZeneca.
Thank you, ma'am. With that,